or if it's the server here. Okay, so we're gonna try to finish up chapter 2 today. So I'm gonna show you some materials from the web to kind of show you how coding works. And this is an important part of understanding how billing is done in an actual healthcare setup. So we were talking about insurance. We know that the last time we were talking about insurance, we know that the vast majority of revenue that comes into a healthcare organization is through interactions with insurance. Okay, so we talked kind of about insurance in general. We'll talk some more. I'm going to come back to that as I have time to. If I run out of time, I'm going to record a lecture that you can listen to offline. The material that I will be going over is in your book, so you can also just read it. So whatever I skip today is actually in your book. Okay, so what I'm going to do is jump forward and talk about how payment largely operates, at least fee-for-service payment operates. So there's this thing called prospective payment. A prospective payment system, PPS. So you'll hear like Jameson, for example, refer to hospitals as either critical access hospitals, like Memorial Hospital we were just talking about, or PPS hospitals, which are prospective payment system hospitals. And the reason that you'll hear executives refer to these hospitals kind of generically in these two classes is it's based on how they're paid. Critical access hospitals are paid on a cost plus basis. So they turn in a report to and this is for Medicare. They turn in a report to Medicare saying, this is how much we spent to take care of your Medicare patients. And Medicare says, okay, we'll pay you that plus a small wedge, like a percentage on top of it. So if a critical access hospital wants to make more money, they have to do more work and they have to show that it costs them more, and then they get a percentage on top of that. The funny money side of critical access hospitals, therefore, is if they do a really good job and save money, their revenues go down, right? Because their revenues are based on their costs. They get a cost plus, right? So if it costs me $100, Medicare says, and this is not the right numbers, but just to simplify, imagine Medicare says, we'll give you 103% of whatever your costs are. So if I report that it cost me $100 to pay to take care of patients, Medicare says, okay, we give you 3% on top of that, so we're going to send you $103, right? So if you save money and you cut the cost down to $50, Medicare says, great job, here's $51.50, right? So you wind up actually bringing in less revenue by saving money. So there's this funny, so the people in the critical access world live in this funny zone of, well, I want to be good, stewards, and I want to provide care at a lower cost, but they face this kind of, incentive to actually not save money at all. Emma, question. Right. So the question is, or the statement is they're then encouraged to do maybe stuff that isn't totally necessary. So yeah, there's no incentive for a critical access hospital, not no, but there's much weaker incentives for critical access hospitals to look at, does Jess really need this extra test? Does Jess really need to stay this extra day? Does Jess really need this extra care? And they don't have an incentive to not do, right, to cut it back. Whereas a PPS hospital, which is what we're going to really focus on for the rest of today and this chapter, is PPS hospitals. So PPS began in 1983 as a reform to Medicare, and it really transformed healthcare. So prospective means before, right? So prospects, right? We're looking for something that happens before. So In 1983, as far back as 1983, right, ancient history, the government recognized that healthcare spending was growing at a unsustainable rate, and so government healthcare spending, right? So Medicare is a government program. The amount of money that people were the government was spending on the Medicare program was rapidly increasing at a rate that was not going to be sustainable. So they came out, and historically what they had done was they had just paid a customary and reasonable rate. So if it was reasonable to pay $500 a day, right? Somehow they came up with customary and reasonable rates. They said, okay, $500 a day for cardiac care, that's a customary and reasonable rate. As long as you come in somewhere around $500 a day, Medicare will, a hospital come in at $500 a day, Medicare would reimburse you at that $500 rate, right? And so everything was kind of on this cost plus, like I described a minute ago, that the critical access hospitals still operate under there. So you would turn in this Medicare cost report, and Medicare would then say, okay, we see your costs and we will give you the cost plus. In 1983, Medicare changed the rules, right? They stopped paying on a cost plus basis, and they implemented this thing called Prospective Payment System, or PPS. It started with inpatient care, and everything became linked to a diagnosis or a diagnosis-related code, DRG. So diagnosis-related code, or DRG. So you're going to hear PPS and DRG and CPT and E&M and all these other funny, there's all these other acronyms. And what we're really referring to is the payment system. And you've got to learn these acronyms in order to be able to communicate in the healthcare field. Okay, so what Medicare said was to hospitals initially, and then it expanded out to physician services as well. Said to hospitals, we will no longer pay you on a cost plus basis. We're no longer going to let you just send us a bill, and as long as it's within that what we judge to be a reasonable range, we'll give you, the cost plus some small wedge. What they said instead was, if Allie comes in with a particular diagnosis, say she's had a heart attack, we're going to have a diagnosis-related code, and I don't know what it is off the top of my head. We could, but I will show you some in a minute. We're going to set rules around each of those DRGs. And we're gonna use historical evidence to say, okay, if somebody comes in with a heart attack, you should do the following services, right? Some sort of scans, some sort of treatments, and Allie should be in the hospital for between, 5 and 7 days in order to get her care. So as a result of all that, because we have this evidence as to how much you should be spending, we're going to set a payment based on Allie's DRG. So Allie comes in with a heart attack DRG, whatever it is. We're going to preset a payment. So you say, Allie had a heart attack. We say, okay, heart attack, you get reimbursed $12,000. And that $12,000 is based on the types of treatment that we've historically seen that we believe are appropriate, the length of the stay that we expect for this particular kind of care, and we've basically got an average that we expect you to be able to provide the care for Allie at this amount, and included in that amount is what we feel is a reasonable wedge for your profit. Okay. So suddenly hospitals went from whatever we did, we got reimbursed at, as long as it didn't come back as being crazy, we got reimbursed at the cost plus, so 100 and whatever % plus, right? All of a sudden the rules changed. And so instead of, hey, we took care of Allie, you know what, it wound up taking us 10 days, we did some extra scans, but here's all our costs. And some auditor looks at it and says, okay, that sounds reasonable. We'll give you 103% of what it cost you to take care of Allie. Instead, when Allie shows up with her heart attack now, and your physician diagnoses her and assigns a DRG of, say, heart attack, that triggers a payment of a fixed payment of, say, $12,000. The goal became then, of course, right, instead of provide Allie as much care as you can get away with, was how do we conserve the care now, right? It flips the model on its head. So Emma was pointing out there's no incentive for hospitals, critical access hospitals, to kind of conserve care. All of a sudden, now you're getting paid $12,000, right, based on that DRG. Now you've got to provide the care to Allie so that it comes in at less than $12,000, because you get to keep, right? So if the payment, and I'm making this up as I go, is equal to 12,000, right, and your costs are equal to, say, 10,000, then your profit is 2,000. And in economics, we use pi to represent profit. So just kind of get used to me doing that every now and then. Profit would be 2,000. So the hospital gets to keep the 2,000. Yes, Jess?
Determined number, is that always assigned?
It can be adjusted, right? So you're saying, is the DRG fixed?
Yeah.
Okay. So question about the DRG and how it's assigned. The physician assigns the DRG, right? So if Allie comes in through the ED, through the emergency department, they make an initial diagnosis, right? If they need to update the diagnosis, hey, it's more serious than we originally thought. You have to be able to, so there's an awful lot of record keeping that goes around this, that you guys will be involved in as hospital administrators, most likely future administrators, most likely, right? And it's why the electronic health record is so important, is to accurately document and support the DRG, because there are different levels of DRGs, there are different levels of care, and we're going to get into that in a minute. You have to be able to, your record keeping, your coding, right, has to be able to support the DRG that you assign. So Allie can't come in with a ingrown toenail and then you code her as having a heart attack, right? That, if you do that, you wind up facing all kinds of fraud things with Medicare, and people go to jail. But it can be adjusted and is adjusted. The DRG, you'll have an initial DRG and then there'll be adjustments made. And coders will often come back and say, hey, you need to add, hey doc, did you do this? Because if you did this, that changes not the DRG necessarily, but the what we'll get into in a minute, the HCPCS codes, which are part of the reimbursement. Yes, Allie. Why is it through Medicare? Well, so great question, actually, right? So why are we talking so much about Medicare? Well, so first of all, Medicare represents today about 60 to 70% of the reimbursements that your typical community hospital gets. So it's really important in that sense. Medicare also kind of sets the standard for the way that most other insurance companies operate. So because Medicare is the lead, because Medicare sets the standards, because it covers so many of the patients, most insurance companies just kind of fall in on what Medicare has set. But Medicare can and did, had the ability, the government had the ability to just arbitrarily make changes, whereas insurance companies would have to negotiate with hospitals and providers. The government can just say, we're changing the rules, right? Whereas insurance companies, if they change the rules, they have to negotiate with their clients, or with their not clients, but with the providers that they are in contracts with. The government just says, this is how we're doing it now, and like it. That makes sense? Yeah, Emma. Yes, exactly. So Emma said, doesn't this now change the incentives so that the providers cut corners, and so that they can maximize the delta, right, the difference between between the payment and the costs. And yes, absolutely that. And so you guys weren't around, but when this all kind of came into play, right, Medicare managed care emerged about this same time on the private side. Managed care emerged, and very similar kind of arrangements were being set out, and still exist, right? So these payments on the Medicare has its own set of payment rates. Private insurers, so Cigna and Harvard Pilgrim, and also negotiate PPS rates with providers, right? So they follow kind of the same structure as Medicare does, and they know what Medicare rates are, so they negotiate. They pay a little better. They pay a little more because they don't have the same negotiating power. But in the 80s, and really managed care started to emerge, and you had these situations where insurance companies were saying, we will only pay this much for a DRG, or they started stepping in and saying, for this DRG, you are only allowed to do these particular kinds of treatments for the people that we insure, physician. And so Dr. Megan, if you're treating Allie, right, and Allie is a Harvard Pilgrim patient, you have to now ask Harvard Pilgrim before, if you're going to do something, there is a set of treatments that Harvard Pilgrim pre-authorizes based on the DRG. If you're going to do something outside of those pre-authorized treatments, Harvard Pilgrim may come back and say, those were not covered treatments. We didn't agree to pay for that, and so you're out of luck, we're not paying for that. And then there becomes a problem between you and Dr. Megan and Allie. If Dr. Megan's like, hey, I did the treatment, Allie, you owe me money. This is where and the insurance companies are like, we're not paying for that. We didn't, that's not authorized. You didn't ask. So you suddenly run into these issues of pre-authorization. And this was a problem. So this became a problem in the 90s that hadn't existed. So physicians were up in arms about this. They hated that. They hated managed care initially. Because suddenly some insurance weenie somewhere was telling them how they could treat their patients, right? And so Dr. Megan says, hey, Allie was my patient. I felt she needed, this scan or this treatment. And so I should be able to just do that and give it to her. And managed care companies were saying, no, we feel like you're just doing that maybe to make some extra money because that we're going to reimburse you, based on what you did. And so if you want to do something that isn't within kind of the in the kind of pre-approved package of treatments for a particular DRG, you have to ask us. And that still exists today, right? This is called getting a pre-authorization. This was all new in the 80s and 90s. And you could go back and watch, old hospital action shows like ER and Chicago Hope or whatever it was, from the 90s, that were these cool shows that your parents watched. And there was always, the bad guy was always the managed care. Somebody comes rushing in on a gurney and we got to, Taylor's got some terrible condition. She's got, late stage cancer. We can do this treatment. Wait, no, the insurance companies won't pay. The evil insurance companies, they're terrible. And so that's usually how the drama plays out. And then at the end, the doctor does it anyway and saves the day, whatever. And the insurance companies are always terrible. So anyway, so this came into play, right, in the 80s with reforms as we realized that healthcare was getting more and more expensive. Right? We talked I think, in the very first class, GDP today, the percentage of all the money made in the United States that winds up getting spent on healthcare is like 18%, right? In the 60s, when we came up with Medicare and Medicaid, it was like 5%. So it wasn't that expensive back then. It was like, hey, we can afford this, right? And then we started paying for it, and it's, and we started paying for it as a kind of as a right? And lo and behold, we wound up spending much more on healthcare than we thought we would spend back when we came up with this cool idea of kind of universal healthcare for old people. So all that said, healthcare is very expensive. So we had to come up with this mechanism. So now that mechanism for inpatient care, it really is driven by the diagnosis-related code. Outpatient care as well. You're not going to, like I kind of was sort of joking, you know, and it isn't normally that extreme, but if you come in for, and your physician writes down a DRG for, infected toenail, and then starts doing a colonoscopy, you're not going to be able to bill for those things. They have to all match up. All right, so prospective payment really based on the diagnosis-related code, and that's particularly important for the inpatient. There are some other mechanisms. There is, you still do see some per diem payments, particularly for psychiatric care. So if you wind up working in a hospital that has a psychiatric unit, or if you work in a psychiatric hospital, most psychiatric care, inpatient care is still on a per diem, per day basis. But today, most inpatient care in the medical setting, non-psychiatric medical setting, is on a DRG basis. Okay, so let me demonstrate here. Let me show you what I am talking about. So I'm going to share my screen, people, in Zoom. There we go. So, can you guys see that? Can you read it? Okay. So this is a bit, by the way, all these Excel sheets are on Canvas. So you can go in and you can download these sheets if you want to look at it. These are examples of ICD-10 codes. They refer to the DRG. This is the DRG system. When you come in to see a physician or to come into the hospital and you are getting your initial diagnosis, the physician will assign a series of DRGs, right, ICD-10 codes to you. And they include, so these are examples, I just happen to have it here in this section, but so if you come in, it's a great Saturday night and you've been out smoking a lot of weed with your friends and you kind of lose control, you go over to, get taken over to Wentworth Douglas ED, and, Taylor takes Caitlin in, and Caitlin's kind of losing her mind because she's been smoking so much weed. And they say to Taylor, what's she been doing? She's like, oh, we were having a great party, and she's just kind of overdid it. We tried to tell her not to, but she's like that. One of the codes that they might put in place then would be F1212-1, cannabis abuse with intoxication delirium. Okay? So there are all kinds of, these happen to be some of the drug abuse codes, so opioid use, cannabis, and you can kind of scroll down here and see there are thousands of codes. Okay? So you can, and they don't apply only to, let me see, talking about vaginal birth, for example. Ordinary, there's those of you that are going to have kids at some point. So I can find so here are a bunch of things associated with having children. So childbirth, pre-existing hypertension, complicating childbirth. So what does that mean? You have high blood pressure, right? And you are pregnant. And so if you have high blood pressure and you're pregnant, right, one of the codes that they're going to use on your diagnosis in order to justify the treatments that they do. So the first piece is the diagnosis, right? In order to justify the treatments, they're going to say, hey, she already had hypertension. Now she's come in to have a baby. She has pre-existing hypertension, and that's causing complications during the birth. If you code that as opposed to a regular uncomplicated vaginal delivery, right? That allows the physician and the hospital to bill more to the insurance company, whether that's Medicare or Harvard Pilgrim. So those are, if you have chronic disease. So there's just an endless list of things that you can be coded for. My favorite is this one. Did you know that there's a code for being sucked into a jet engine? So if you get sucked into a jet engine and somehow you survive and get to the emergency department, they will code you as a V9733XA sucked into jet engine initial encounter. If somehow you manage to survive that and get it done, have it happen a second time, you'll be coded as a V9733XD sucked into jet engine subsequent encounter. That's a second time. If your luck is amazingly bad and you get sucked into a jet engine 3 or more times, your code would be a V9733XS. I'm not sure how you wind up with the first one, and that you're not just like pieces on the ground, but somehow if you manage to do it, that's kind of the so that's the level of degree. But you can see hit by an object falling from an aircraft. It's there, right? So it's kind of amazing the level of detail that's out here. So this is the ICD-10 codes. They were implemented, I want to say 3 years ago. Before that, we had been the ICD-9, and we've been ICD-9 for many years. We will be now ICD-10, hopefully for many more years. So when I talk about the diagnosis-related code, you're talking about DRGs, right? And so you're talking about DRGs, and you're talking about looking at the ICD-10 codes. So this is the International Classification of Diseases. International Classification for Diseases, 10th edition. So they're hierarchical, right? So you start with, sucked into a jet engine, and then more detail, sucked into a jet engine first time, and then it becomes more and more detailed. All right. So you've got your diagnosis. So the key to the diagnosis is that now justifies the treatments that you're going to get, either from the hospital or from the physician and or other providers, right? And so the DRG can trigger a payment, triggers a payment for the hospital, but it doesn't necessarily trigger a payment explicitly for the physician. Typically what the physician has to do is now code for the work that he or she actually does to you, right? And so that work is covered by the Healthcare Common Practice Coding System. Or better known as HCPCS. HCPCS. So, Healthcare Common Practice Coding System, HCPCS. HCPCS is a list of codes corresponding to anything done to the patient, right? Everything from an injection to a surgical procedure to I don't know, ear lavage, washing out your ear, to whatever else, whatever's done to the patient, and including, and what we'll talk about in a minute, are basically office visits with providers. They're probably the most common codes, right? And so within within a subset of the HCPCS are common procedural terminology. or CPT codes. These are what provides the language for providers. So HCPCS will include, it doesn't just include things done to you, right? It includes other stuff like we provide you a wheelchair, right? That's included in HCPCS because it's all about the billing, right? So your coders, right? You as a practice manager are going to have these coders. The physicians are going to be like, I had a DRG of, or ICD-10 code, these diagnoses coded them with my ICD-10s, and then I did the following things, and this will come out of the CPT codes, which are a subset of HCPCS. These provide a common language for medical procedures, right? So it's common, and it's a common set of codes, and it is developed by the AMA, American Medical Association, right? So the American Medical Association kind of looks at and develops a list of these codes. These are all the things that our physicians do. And then we have a list of what's called, associated with these HCPCS are what we call resource-based relative value scale, or RBRVS. This is a system that assigns a relative value unit, or RVU, to the HCPCS. Okay. So you have a HCPCS, you have your, and I will show you the current HCPCS list with its associated RVUs in a moment. You can download this from the Medicare website, but this is a negotiation between the government and the AMA, and what the RVU is meant to measure is the amount of effort and cost associated with providing a particular kind of care. Okay? And so each HCPCS code, in particular CPT codes for providers, each HCPCS code has a RVU value associated with it. And the RVU value becomes the basis for billing Medicare in particular. Fee-for-service usually is built around, all the fee-for-service things are built around that. If you talk to most physicians who are, in particular, physicians who are employed. So when I talk with, physicians at the different group practices where the physicians are employed, they often, in their contract, they often have an RVU target that they're expected to meet each month. Right? It's written into their contract. You must generate 1,000 RVUs each month in order to get your base salary. And then you earn bonuses. This is pretty typical. You earn bonuses if you are above that RVU target. If you repeatedly fail to meet the RVU target, you're going to wind up having difficult conversations with the leadership of the CMO first, and then the CEO, and then you're going to find that your contract doesn't get renewed, right? So, well, this is serious business on the provider side. So let me show you a sample of I thought I had it up. Hang on a second. All right, I will find that later. I'm going to show you some basic HCPCS codes that refer to So these are some of the most common outpatient CPT HCPCS codes, right? HCPCS is kind of the bigger overarching system. CPTs are a subset of the HCPCS. So these are, I want you to know these, right? You don't have, and they're actually pretty simple because there's a system behind them. So you really only have to memorize how the system works. But you'll need to know this, okay? You have a HCPCS code, CPT code of 99201, right? What does that mean? Well, you read over to short description, office/outpatient visit, new. So a 99201 refers to an office visit with a physician or other provider, and this would be typically PA or nurse practitioner who are able to do diagnostic work. You do a 99201 means you're a new patient, means they've never seen you before. So if Deborah goes in to see Dr. Samantha, right, and Dr. Samantha has never treated Deborah before, she would code a 9920. I'm going to pause there for a second because the 9920 refers to new patient, outpatient visits of with a new patient. If you go down to line 10, you see that it switches from 9920 to 9921. And if you read over, all the rest of those say office outpatient visit at EST, which refers to established. So if Deborah had been, if Samantha, Dr. Samantha had been Deborah's physician for the last 5 years, and Deborah calls in and says, hey, I need to get seen because I've got, scratchy throat, and Samantha says, come on in. She wouldn't code a 9920 whatever. She would code a 9921 whatever the fifth digit is. Depending, and so what the fifth digit captures is the level of intensity. So you'll see here, going from line 5 down to line 9, you go from 99201 to 99205, measures the level of intensity of the visit for a outpatient visit with a new patient. Then you have 99211 to 99215, which measures the level of intensity of an outpatient visit with an established patient. So the difference between a 9920, say 99201, and a 99211 is with a 01, it is a new patient that the provider has never seen before. With a 11, with a 99211, it is a visit with an established patient visiting their provider. So they have an established relationship. So the 1 to 5 measures the level of intensity. 99201 and 99211 are almost never used. Basically, it would be like you come in, you say hello, and you leave. Right? It is a number. I've not really come across 01s and 11s much in my review of billing that I've done. Typically, your typical visits are going to be either the 99203, 99204, or 99213 or 99214. And what that basically, like a 992, and there's a bunch of guidance that I'm not going to be able to give you on this because I don't have the literature on it, but you could look it up, actually you could look it up. It's relatively easy to look up on the web. There's a bunch of guidance that says what qualifies for a 99203. Well, it's probably going to be something like a new visit with an outpatient visit with a new patient lasting about 15 minutes of moderate complexity. So that's right in the middle, right? Think of the 3-level codes, either the 99203 or 99213, requires kind of some level of diagnostic thinking on the part of the provider, whether that's a physician, a PA, or a nurse practitioner, right, to diagnose the illness or injury that the new patient or established patient, depending on which one you're using, has come in with. And then, and they're typically, so there's kind of a time component and there is a level of complexity. Those are the two things that really drive the appropriate CPT code. So time component and level of complexity. So typically a 99203 is going to be your vanilla 15-minute visit with your doctor, right? 99204, 99214, slightly more complex. Maybe you're staying 20 to 30 minutes, slightly more complex. And finding and fine-tuning between 3 and 4, is something that we don't need to worry about in this class. Just bear in mind that there is somebody in every healthcare organization that spends their day teasing out the fine details, and it's all about what the doctor says they did in their notes. So the doctor might code a 99204, and then the coder gets it and looks at it and says, you really only spent 10 minutes with the person. You only came up with one diagnostic code. The complexity you're documenting here does not warrant an 04. Instead, we're going to downgrade that to an 03 or an 02, right? And so you'll hear a lot of discussion in organizations about teaching physicians how to document, right? And physicians hate that. But that's how this works. You have to be able to document the level of complexity of the decision-making in order to justify a higher level code. So your typical physician visit for you guys, for example, is probably going to be an 03 or a 13, because most of you probably are otherwise healthy. Now, if you have pre-existing conditions, so some of you, somebody in this class almost certainly has type 1 diabetes. You're born with it, you've had it for your whole life. Somebody in this class probably has hypothyroidism and has to take Synthroid every day. Right? Once you start having, or somebody in this class is over 50 and has a variety of cholesterol and high blood pressure and yada yada yada, right? So as you get older, you're going to have all these conditions that are going to complicate an otherwise relatively simple visit, right? So if I show up to my physician, I have a what might be an otherwise relatively simple thing, like I've got a cough, but I have pre-existing conditions. They may have to do some medication management. The decision making becomes more complicated because if they want to give me a medication, right, and I'm already taking 3 medications, they have to figure out what's the interaction between the 4th medication and the 3 that I'm already taking. And they might want to review, like, okay, well, how have you been doing with your diabetes, since I last saw you, or your congestive heart failure, and so on, right? That justifies going up to a higher level. So what you will see is when you have a physician practice, for example, with an older population or an older, sicker population, you will see a tendency toward these higher codes, the 4s and the 5s. Right? How does this generate a bigger bill? All right, so there are 3 components. So let me just reiterate. The reimbursement to the physician is based on total RVUs. And there are 3 components to calculating the RVUs. You're going to have work RVU, a practice expense RVU, and a malpractice RVU. Yes, Emma. All right, people of Zoom land, can you hear me? Give me a thumbs up. All right, thank you. Sorry, I think the internet is unstable and that's why we lost you. So hopefully we're back and we're, So let me pause. Emma had a great question, was if you come into, say, the emergency department, you have a broken bone, but you also have other things going on, say a mental health diagnosis, or maybe you have cancer, you know, and maybe those things are unrelated to the fact that you went out skiing and you broke your leg. So you'll wind up with DRGs that cover all of those things. So every time, if you have diabetes, every time you go in to be a physician, they're going to write down one of your ICD-10s is going to be diabetes, whatever the appropriate code is, going to be diabetes. So if you go into the emergency department to get seen, and these are not ED codes, there's a whole other set of codes that are used for emergency department visits. These are outpatient doctor visits. So you go to see your physician at their office, this is what they're going to use. You're going to get coded for, so if you go to the ED and you've got pre-existing conditions that may complicate the treatment for, say, the driver that brought you in there, which was the broken leg, all of that is going to be coded in, and it will raise the level of complexity because the physician has to exercise more judgment about how they treat you. Yes. Yes, yes. If you're on a medication every day, and it adds to the complexity of the decision making. So these codes are meant to capture the amount of kind of mental effort that the physician is exercising in providing the care. So if you broke your leg and you have hemophilia of some sort, right, resulting from whatever, maybe it's because you're also on a blood thinner, that's going to complicate the treatment. And so that would be a higher level of care than if you just came in, you were otherwise healthy 20-year-old and you broke your leg skiing. So if you come in and you have complicating conditions, it's going to raise the level. So that's a good example, right? So back when I used to work, I remember working when I first kind of was learning about these codes. I was working at Fort Polk, Louisiana, and I had a physician that I really liked. She was an internal medicine physician, and she handled a lot. She did primary care for a lot of our older, sicker patients. And most folks in the military health system are young, healthy people, and they're relatively, and they're typically young, relatively healthy family members. But we also take care of retirees in that system. And so this physician used to take care of a lot of the more complex old retirees. And so she coded a lot of 4s and 5s, right? And the difference between a 3, say, is like a 15-minute visit. A 4 might be, and I'm kind of working off my memory here, say, 20 to 30 minutes, right? And a 5 is typically going to be 45 minutes to an hour. But it's not just the amount of time. You can't, Chloe can't come in to see the doctor about a cold, right? She's like, I know I've had stuffy nose for 6 weeks, and the doctor's like, sounds like you've got an infection. I'll give you some antibiotics. Tell me how school's going. How's the kid? How's the wife and kids? How's whatever? And then we spend an hour talking. That doesn't count, right? As an hour. The hour has to be dedicated to the complexity of the treatment. And so you have to document not just the time, but the complexity, right? There's really kind of 2 drivers there. So if Chloe comes in with, some sort of, head, what's the word I'm looking for? Nasal infection, right? What is it? Sinus infection. I just couldn't bring it up. If you had come in with a sinus infection and you're otherwise healthy, right? That's going to be maybe a 3 or a 4, right? But if you come in with a sinus infection and you have cancer, right, and you're being currently treated for cancer, that's going to turn into a 5, because I'm going to have to do a whole bunch of evaluation to see, okay, is it just a sinus infection, or has the cancer moved up to, into your nasal cavities, right? So, and I'm not trying to be, this is our business, right? So I'm not trying to minimize any of that. It's just that's what's going to drive the complexity, and that's going to be much more complicated. If you have a patient with cancer, right, it's going to be much more complicated pretty much across the board than if you're an otherwise healthy young 20-year-old. That make sense? All right. So I think I lost you guys on Zoom as I was starting to talk about how the billing actually works. Okay, so let's focus on a 99203 for a moment. There are three components we're going to consider. You can ignore the conversion factor for the moment. The first component is the work RVU. The work RVU is meant to capture the actual work done by the provider. It's the difficulty of doing, and the difficulty and the length of time it takes for them to actually do the procedure, or in this case, the office visit. So you can see that a 99203 gets you 1.42 RVUs. A 99202 gets you 0.93 RVUs. So you're making 50% more, roughly, right, by coding a 99203 versus coding a 99202. So that's going to drive the reimbursement. So a physician is motivated, right? And when I say physician, just lump in their PA and a nurse practitioner too, right? But a physician is motivated to try to raise the level of code, because you can see the difference between a 99203 and a 99204 is a whole RVU, which is a big deal, right? It's going to be the difference of like an additional $40 for the visit, just kind of off, making a rough estimate. And then a 99205 is 3.17. So a 99205 gives you more than twice as many work RVUs credit as a 99203 does. So your coders, the physician, and then the coders that work with the physician have to make sure that when the physician codes a 99205 and when the organization turns in the bill, that it's well justified, well documented. Otherwise, the insurance company and/or Medicare is going to kick it back and say, we're not paying that. We think that you just spent an hour talking with them about sports. Not, this should not have taken an hour. Right? Based on the coding you sent, based on the supporting documentation you sent us, should not have taken an hour to take care of, Chloe, right? So you can see the differences, right? And then an 01 is a half an RVU. So the 03 is 3 times what a 01 is. A 05 is 6.5 times what a 01 is. So there's a pretty big range of between an 01 and an 05. The only thing you really have to keep in mind for test purposes is the 1 to 5. It represents a range of complexity. So I might ask you something like, Saffron brings her grandmother in to see the physician, right? And grandma has diabetes and congestive heart failure, and she's having she's had a cough for 2 weeks. What's more likely? Would a 99211 or a 99215 be more appropriate? What do you think? A 5, right? Because she's old. She's her underlying. She has maybe an otherwise relatively simple situation, but she's got a bunch of underlying complexity there between her age, her various pre-existing conditions. Right, that's going to create a situation where the physician's going to have to spend a lot of time with her, and you can know a 211 is basically like, you have high blood pressure, and I've told you to come in once a week to have your blood pressure checked, right? And you're going to come in. A nurse might take care of you. I might not even see you, or I might just, hey, how you doing? Good. All right, we'll see you next week. Right? That's a 99211. Blood pressure check with the nurse. I walk by, say hello. You say you're good. I say, all right, see you next week. That's a 99211, right? 90-year-old grandmother with congestive heart failure, diabetes, and a history of lung cancer, and now has a persistent cough. That's going to require some thinking, probably some ordering of some tests and so forth, right? So that's kind of, I'm going to make it that plain to you, right? So that you should know the difference between that 1 to 5. 1 is less complicated, 5 is more complicated, right? And is it a new patient or an existing patient? And once you know that, you're able to you don't need to remember all the in-betweens, right? You need to know that A 99203 applies to a new patient coming in for a moderate level condition. A 99213 it represents a established patient coming in for a moderate level of complexity. And then you need to know, 5 is, as my friend, the physician that I was talking about, referred to them affectionately as her train wrecks, right? So she referred to these old sick people as train wrecks affectionately. She loved her patients. I'm sure she still does. I'm not in touch with her anymore. But she, each of them was, multiple medications, multiple conditions, and they all took forever to take care of. And so she coded a lot of 4s and 5s, almost exclusively 4s and 5s. If you're running a pediatric clinic or a family practice clinic where you're seeing mostly, or family medicine clinic where you're seeing mostly, mostly kind of maintenance stuff with minor illnesses, you're going to see a lot more 3s, some 2s, and probably some 4s. Occasionally, you're going to see a 5, right? But it's going to be unusual. All right. So they got a work RVU. That represents the effort by the physician. Here's another thing you have to discern between. You have to pick the right practice expense RVU, and you only get to pick one of them. There are 2 going to be offered to you, right? There is a non-facility RVU and a facility RVU. What does that mean? A facility refers to a hospital. If you are doing a visit or a care or this kind of care in a hospital, the hospital is providing you, remember I said, think about a hospital as a doctor's workshop, okay? The hospital is providing the doctor the workshop. They get to come and they get to do their work. So it's like, I don't know if any of you guys do art stuff here on campus, but there's a ceramics shop, right? So like if you took a ceramics class and you got permission, now you can come and use the wheel and the equipment in the, at the ceramics shop, right? That's different than you bought your own wheel, right? It's just throwing, what I'm talking about with ceramics, like you're throwing, what was the movie with the ghost, and is it called Ghost? With Demi Moore and Patrick Swayze and, no bells. Chloe knows what I'm talking about, right? And he's like reaching around her and they're playing the music and, okay. All right, you gotta go good, get your 90s trivia up. You're gonna miss a lot of this class if you don't keep up with your 90s trivia and you don't know your 90s movies. Anyway, so the difference being, so imagine this, you are interested in doing, making pottery, right? And you have free access to UNH's pottery studio, or you can buy your own wheel to make your pots, right? That's kind of the difference here between a facility RVU and a non-facility RVU. With a facility RVU, the physician is coming into the free workshop and doing their care. And somebody else is paying for all the equipment that the physician is using, all the space that they're using, right? And so the practice expense for the facility RVU is relatively low. Think of the practice expense as kind of being the equipment and the support staff and all the other stuff that wraps around the physician doing the care. So if you're going into the free doctor's workshop called a hospital, you are not going to get compensated as much because you're not laying out the costs. Now imagine instead, going back to my little pottery example, instead you bought your own wheel, right? And you're making the pots in your basement. And you had your own kiln, right? That's a pretty significant outlay of expense. You're gonna, the wheel's a couple $100, a kiln is probably, $1,000. I don't know. I don't do pottery, but it's not cheap, right? In that case, if you were gonna sell your pieces, you'd have to sell them for a higher price because you have to cover the fixed costs. We'll get into this pretty soon, but the fixed costs of having bought the wheel, bought the kiln, right? Using your own space. So that's the difference between the facility and the non-facility. With the facility RVU, the assumption is if you, the physician, are going into somebody else's space using their equipment and their personnel to support you. And so the additional practice expense that you're going to get is relatively minimal compared to the non-facility RVU, which is the assumption that you're doing the equivalent of pottery at home, right? You are now in your office using your equipment and your staff to provide the care. So at 99213, you're going to get the work RVU, the 1.42. And if you see the patient in your office using your nursing staff and your equipment, you're going to get the non-facility RVU. So you get 1.42 plus 1.48. as the practice expense. The practice expense is meant to represent the cost of providing the care, the support staff necessary, the physical space necessary, and so forth. Okay. So yeah, go ahead, Safra. The what? PE means practice expense. So you see up here, non-facility PE, facility PE, RVU, practice expense. Okay. So you're going to pick one or the other. You don't get both. You're either in a hospital or you're not in a hospital. And so if you're at your clinic that you own and run or rent or whatever, you get the non-facility PE RVU added on. If you're doing the care in a hospital, you get the facility RVU, facility PE RVU. So you still get some extra kicker there, but you just don't get the same amount. The third component is MP RVU. Anybody want to guess what MP stands for? Malpractice, good. Malpractice RVU. This is meant to represent the amount of insurance costs, basically, that you incur to provide the care. Okay? It's a relatively small number. If we were to look at things like, surgical interventions, which I'll see, we have it. I'm just not going to show it to you today, but you can download. I've loaded up all the CPT code, a full list of HCPCS codes. You can look at them and see that. So you're going to get added on the malpractice expense. Now, if we go down to 99213 as opposed to 99203 and compare, notice that the 99203, it has a much higher work RVU than the 99213. Why would that be? Okay, so Allie's saying because one's established relationship and the other is new. All right, go ahead. Good. Sarah? Okay, so why does that matter? Onboarding, okay. What is it, Jess? Background information, right? So so the idea here is if I know you, right, if I'm Caitlin's physician, I've been seeing Caitlin for 10 years, we've got an established relationship. I can look at my records and I can say, all right, Caitlin, I know you're a young, healthy person and you don't have any underlying, major diseases. So I can deal with you much more quickly than if I don't know these things, right? So the new patient gets higher work RVU than the established patient because presumably you've onboarded, right? You've brought the patient in to your system. You're not doing any sort of initial history, right? So hopefully, if you go in to see the physician with an established physician, they can pull up their records and be like, all right, I've seen you 8 times over the last 4 years, and I have a pretty good idea what your health condition is. With a new patient, you're going to have to invest a lot more effort and time. So that's why there's a persistent difference as you go down. Every single one of the 01s is, of the 0 series, right? The new patients, for the same level of complexity, the RVUs are higher, right? So a new 05 is 3.1, an established 05 is 2.11. Significant difference. And that carries over to the practice expense as well as the malpractice, right? All this stuff, it's higher for that first visit. But once you've had that first visit, it goes down to the established, okay? So what do we do with all this? I'm going to show you now a couple of examples. All right. Let's assume a 99203. What does that mean? What do we know that means? That's a new or established patient. New patient because it's a 0x, whatever it is. And a 203 tells me it's what level of complexity? Moderate, mid-level, right? So 99203, mid-level visit, mid-level complexity and length, right? Because it's going to be time and complexity of decision making. A assume that it is, so that's going to generate my work RVU of 1.42. Assume it is in a non-facility situation, so we're getting seen in a clinic someplace, right? You're going to get a non-facility practice expense, and then you're going to get a malpractice RVU of 0.15. So those are all coming off of the sheet we looked at a second ago. What did we not have? Well, there's this thing called a GPCI, geographic, I always forget what it's called. Geographic, it's an adjustment for geography. So it depends. So if you're in New Hampshire, for example, there's a GPCI for New Hampshire. There is a GPCI for Greater Boston area, right? Those of you from Boston know it's more expensive to live in Boston than it is to live in New Hampshire. And so there is a geographic adjustment that is applied to each of these RVUs, right? So the work RVU gets a multiplier of 1. The non-facility RVU gets a multiplier of, or the practice expense gets a 1.04 multiplier, and the malpractice expense gets a 0.98. So the idea here is we've got some mid-level, someplace in the country is a 1 across the board, right? And so New Hampshire is about middle, right, in terms of expense relative to the work RVU, a tiny bit more expensive for practice expense, and maybe a little less litigious than maybe some other areas. When I moved from Hawaii to Louisiana, I moved from living in Honolulu, big city, to very, very rural Louisiana, right? You know, town of 20,000 or something like that. My car insurance, I thought for sure would go way down because I was living in the city where there's, you know, bazillion cars running around all the time, to, you know, cows and alligators, lots of alligators and snakes in Louisiana, right? And I thought for sure my insurance would go down, and then I get my insurance bill and it's actually higher in Louisiana than it was in Honolulu. Why would that be? I'm like, you know, I'm a bit stunned. So any guess why that might be? Okay. Maybe. Yeah, okay, so you might actually be covering more mileage. Yeah, that'd be fair. That wasn't the reason, but that's potentially fair. What's that? Hurricane tornado chance? That was not the major component, but so there's some additional risks. It's just a much higher level of litigiousness meaning people sue each other a lot more in Louisiana than they do in Hawaii, apparently. I didn't know this. There's a lot more fraud too, by the way. And so insurance companies, so the malpractice expense, if you will, that I wound up having to pay, you know, the higher rate that I wound up having to pay, my insurance company basically told me was, look, people just, you know, make a lot more claims in Louisiana than they do in Hawaii, and that's why you're going to pay a higher rate, because the overall risk, the community risk, not you personally, but the community risk is more likely that if you get in an accident, somebody's going to be like, oh, my neck, I'm going to have to go, I'm going to have to be out of work for the next 6 months, and you're going to have to pay for it, right? It's just a lot more fraud, basically, in Louisiana. Okay, so what we do then is we take the GPCI for each of these and we multiply it by the appropriate RVU. So the GPCI for work RVU is 1.0. We multiply that by the 1.42, and of course anything times 1 is itself, so we get 1.42. We take the 1.04 GPCI, multiply it by the 1.47 for the practice expense RVU, we get 1.53. Remember, you're going to either have facility practice expense or non-facility practice expense. I'm going to give you both, and I'm going to tell you the situation. This will be the kind of scenario will be is like, you know, Caitlin goes to see her established physician at his office and has a mid-level level of complexity thing. You're going to know that's a established visit, so a 99213, right? Established visit, non-facility RVU. And that's basically all you need to know, right? So here, I'm not counting the facility RVU, I'm ignoring that. And then I've got the malpractice expense of 0.98 times 0.15. I add across to get a total of 3.1 RVUs, right? Adjusted for the geography, I have 3.1 RVUs. All right, I don't get paid in RVUs, I get paid in dollars. And so there is a conversion factor of $36.09 per RVU. So more RVUs I have, I multiply by $36 and I get more money, right? So 3.1 times $36 is $111.85.
Are you not multiplying across for all of the values?
I am adding these three to get my 3.1, and then I am multiplying 3.1 times 36.09.
Okay.
So I'm not multiplying 1.42 times 1.53 times 0.15 times 3. Is that your question?
Yeah.
No, I am adding to get my total RVU, and then I multiply the RVUs times the conversion factor.
Okay. Okay. Thank you.
Yeah, because otherwise you'd wind up with like a mid-level office visit costing $2,000. Right? So it'd be a lot of money. So, you know, do apply some common sense as well when you're doing one of these problems. If you come up with something like a mid-level established visit cost me $2,000, you've probably done something wrong. Right? So add the different RVUs to get a total RVU. Multiply total RVU times the conversion factor. That gives you the total amount allowed. All right, so that's my 99203 with a in a clinic. What's the difference between the first example and the second example? Well, it's still a 99203, right? So same level of complexity, still a new patient. So I get the same work RVU, but what I'm identifying here is it's not happening at the doctor's office, it's happening in the home. So in that case, you're going to get the facility RVU, which is lower. You're still multiplying the facility practice expense RVU by the GPCI for New Hampshire. That gives you that amount. You add the work RVU, the adjusted work RVU, the adjusted practice expense RVU, the adjusted malpractice expense RVU to get a total of 2.19 RVUs. Multiply that by 3609 and your allowed is 7914. Why again? Because in this case, you're assuming that the physician is using somebody else's equipment and somebody else's staff to do the visit. And so they don't get compensated as much because, oh, by the way, the facility will also be submitting a bill, right, separately from the physician to the insurance company. So the insurance company is like, no, physician, you don't get to bill the full amount because I'm going to have to pay the hospital for providing you the setting to provide the care. Yes, Kate. They're going to build it a little bit differently, but they'll still consider it. They're still going to be built. It's going to be built around the CPTs. So, but I will focus you on the physician costs. All right, and then the third variation here is instead of a 203, it's a 213. So that means mid-level established patient, right? Lower work RVU, lower facility RVU, but it's a non-facility practice expense RVU because you're back in the clinic again. So no facility RVU, you ignore that. Do the same thing. The GPCI times the RVU values for each, add them together to get the total RVU, multiply it by the conversion factor, and you get the allowed amount that the physician is allowed to bill Medicare. Now this is a Medicare scenario. There are other variations, and we don't have time to get into them. I will spend some time talking a little. I'm going to record a video going over some of the variations on insurance that you can read about it in your chat. I'm basically going to kind of go through what the chapter says. You can read the chapter. You can listen to the rest of the video. This example is on Canvas under the Other Interesting Things module, I think it's called, and it's called. I can't move this. Sorry, it is called RVU calculation example. So that is available to you on Canvas. So you can pull that down to practice with it. All right. So next time we're going to show, I'm going to, between now and Thursday, I'm going to record an additional I'm going to record. There we go. I'm going to record an additional video